Good afternoon. Today my presentation is divided in the two parts. The first half is about the case discussion and the second half is about the kidney dialysis and kidney transplant. So I will take the first session. So let's begin with the case. A 61-year-old male patient admitted with fever, scrotal swelling, vomiting, loose stools. Before the day of the admission, he had all these complaints 4 to 5 days. So on examination, we found that he is dehydrated, oliguric, BP was 90 by 60 and he was tachypneic. So we initially admitted him in the ward. Further investigation showed HB was 9, total count 15,600, platelet was on the lower side and creatinine was 6. ABG suggestive of severe metabolic acidosis and the CRP is sky high 350. So after investigation we diagnosed as Fournier's gangrene, sepsis with AKI and initial treatment of IV antibiotics, cefoperazone, sulbactam, IV fluids, NSRL, antiemetics and infusion of the soda bicarb. Initially patient was improving, but on the second day patient worsened, hypotension worsened, tachypneic, oliguric, so patient shifted to the ICU. So here comes the teamwork. A team management of critical care and nephrologists was started. So we urgently started the escalate the antibiotics to meropenem. After the initial resuscitation, the hypotension was not improving, so we started noradrenaline infusion with soda bicarb infusion and measuring the CVP, we titrate the IV fluids. After initial few hours, the urine output was not maintained. So we started the slow low efficiency dialysis in the ICU and along with that 4 PRC and 4 FFP was given. After that we have taken the surgical opinion and they said that it's an surgical emergency, so we have to taken the patient to surgical debridement and orchidectomy. So this is kind of a double-edged sword. A patient was deteriorated, X-ray was not good, bilateral pneumonia, and he was gradually went on the BiPAP support. Echo was done for the surgical fitness. It showed RWMA with EF of 25 and fluid was reduced. So initially for the sepsis control, we have to give the fluid resuscitation, but after the echo, we have reduced the fluid and we started the diuretics. The antibiotic along with meropenem, we started colistin and according to the sepsis guidelines, we have given the hydrocortisone. So as I said, it is a double-edged sword for us. So if we have taken this patient to the surgery, we might lose the patient. So we have taken the on-table death. And if we are not going for the surgery, then also we might lose the patient in ICU. So what to do? So as per sepsis guidelines, we have to remove the source of infection. Otherwise, we cannot control the sepsis. So the benefit is removing the source of the control. We can survive the patient. So the survival of chances of survival are more. And the risk is patient was cardiac compromised, anesthesia risk, and that, as I said, death on table. So we have taken the chance. We intubate the patient and then shifted to the OT. After the procedure went well, patient came back to the ICU and the next day we have extubated the patient. Everything was uneventful. Suddenly after the one day we have to re-intubate the patient because of fluid overload and pneumonia and so many things. So further course was very difficult, so many ups and downs was there, required comprehensive management. We need slow and very careful from the ventilator, parenteral and enteral both the nutritional supports. We have added antifungals like caspofungin. Intermittent dialysis was done and ultimately the patient went out of the AKI. IV albumin and hydrocortisone, chest and limb physiotherapy and diet. These both are the very good and essential part of the critical care. After good nursing care, counseling and psychological support, after the 15 days, patient came out of the ventilator. On the 22nd day, he was discharged with normal serum creatinine 1 and taking food, walking and going home by himself. So this is the flow chart. On day 1, we started. Thank you. On day 1, we started higher antibiotics, vasopressors and timely dialysis. On day 2, surgical debridement. This is the most important part to control the source of infection. The second day, we have already started colistin. Day 4, patient was re-intubated. On day 5, dialysis stopped, AKI was recovered. On day 15, patient was extubated successfully. And on day 22nd, we have discharged him with happy face. So my discussion is on acute kidney injury is seen in 20 to 30% of the ICU patients. So it's a very tricky when the AKI patient deteriorate and went to the ICU and put on the mechanical ventilator. This is a very tricky patient in sepsis with AKI because these patients initially need fluid resuscitation and afterward they need fluid de-escalation. Like antibiotics, we also do the de-escalation in the IV fluids. AKI increases mortality as high as 50% and also increase the morbidity and cost of the treatment.
Madam, 2 minutes left.
Yes. Okay. In sick patient with AKI, ICU requires a team approach. A nephrologist and a good intensivist can be a better care of the patient. So early hemodynamic stabilization with IV fluids and timely introduction of the vasopressors is very important. Appropriate antibiotics with escalation and timely disc escalation, the both are very important. Dialysis or CRRT are life-saving in AKI patients. 2D echo, DVT prophylaxis, bed sore prevention is also important in the long-term ICU patients and proper nutritional and physiotherapy care. Thank you so much, and I would like to invite the Dr. Umesh Godhani to carry forward the case, and he will present to you about the dialysis and the kidney transplant.